have a tight agenda. Some of the speakers have to catch a flight quite soon, and then they should be leaving at sharp time at 10. So then, for that purpose, I invite all the speakers to join me at the podium, and then so Eugenia, or he will join later, no problem. He will be invited to join later. So, if not, the people always says that we are not on time, that we are showing that we are very on time. And so the purpose of this round table is to change a little bit the classical way to present results about the aging cohorts. And as you see, there are different names for these cohorts: POPI, JEPO, AGIV, and over 60. I don't know if you should vote. Which one do you like more? Which name do you like most? I don't know, POPI is like more fashion, but all are pretty good. Well, if do you want, while we are discussing between us, you can also raise your hand and ask questions. So, Patrick, please join us in the podium. And so you can interrupt or you can ask, raise questions or whatever you want. So, just let me start because, again, the purpose is that that the speakers present all the results they have and the knowledge they get. And then is the idea that the HIV-infected population is suffering an accelerated aging. Is this a fake news, or is true, or what do you think? So let's start by Peter, please.
Okay. Well, if I look at our own results, I would say if somebody is properly treated during that treatment, we at least didn't find any evidence of accelerated aging if we looked over time. Short period, we looked at 2 years. However, if we looked at aging markers at the beginning, at entry into the cohort, we did find a difference between the HIV positive and HIV negative cohort, which means that something must have gone on in the past. So it could be that if you, and we haven't looked at that because we haven't been able to look at it, but I think if you would do a prospective study which you can't do today, but if you would do a study where you would take somebody who's infected, not treat and observe for a long period and look at aging markers compared to appropriate controls, you might find accelerated aging, which would then explain why we found a difference at baseline. But the difference in a treated cohort stays the same in our hands over time, which I think is good news.
Yeah, well, let's finish the first round, and then Giuseppe.
And so I think that it's always, first of all, necessary to understand that one peculiar issue when you describe aging is the fact that each one of us age in a different way. And so from a clinical point of view, the capacity to describe stochasticity, that is the being so different one another, is so important. And so what Peter says, I totally agree with him. Nevertheless, in a clinical perspective, it's also important to understand whom of our patient is aging more rapidly than expected. And so I think that as clinicians, this is what we need to detect. And so what is the way to be able to describe individual trajectories of aging so that to understand within our population what are the most vulnerable people. Going back to what Peter was saying is that definitely we were able to describe, and actually this will be published soon, I hope, that in the most recent year, actually, the proportion of people being frail at a younger age is reducing, and we are not just increasing life expectancy of the patients, but we are somehow compressing frailty to an older age. And this is also very, very good, because it means that in most recently diagnosed and better treated patients, the aging profile turns to be more similar to the general population than what has been in the past.
Virginia.
I agree with you, and I always say that we have to distinguish two populations in our HIV-infected patients. Patients who were treated with old treatments and all antiretroviral drugs that spent many, many years without treatment, and probably in this population age faster and earlier. And probably, we don't know it, we don't have time to see, the people who started treatment at the beginning with the new drugs are different, no? And they are not aging, or they are aging at similar to and people not infected. So it's different, and we can't put in the same, no? The same answer is not the same for both populations.
Paddy?
So I would say no. I don't think that there's accelerated aging in HIV, and I think that there's no clear evidence from any of the studies to show that any particular disease is happening at an earlier age. I think biologically, when we talk about people living with HIV, we try and classify them based on a biological age. I think that's, I don't really see that there's much sense in that. I think biologically, people living with HIV are disadvantaged. Whether that disadvantage translates into a worse clinical outcome hasn't been defined. So from my perspective, there's no accelerated aging. For a subpopulation of those that are biologically disadvantaged, they may be at greater risk of an accentuated aging profile, but I don't think that there's accelerated aging. And I think that what's happening in HIV is that you have it's almost like medicalizing a normal process. Everyone gets old. And what we should be aiming to do is to maintain health as people get old, rather than turning getting old into a medical condition, because it's not.
So, Giovanni raised a point that I always used to tell to my patients, that be aware that because you are HIV infected, you will probably live longer than if you were not infected. And of course, this is for some sort of supporting her mood and not being afraid of dying because of HIV. But my as a clinician, I do think that some patients have had significant benefit of undergoing regular, every 2-3 times per year, controls that will prevent many diseases that if they were not infected, they would have suffered before. For instance, those smoking a lot, prevention for cancer, early diagnose. And you mentioned that, Giovanni, and then I want you more to extend on this.
Well, first of all, we need to distinguish what are projection and what are the data. Because yesterday, in the revision of literature, it was clearly shown that, according to the data we have, elderly people die 2.5 times more than the general population of the same age. And so, again, because maybe we HIV clustered more vulnerable population, but also we know that cancer are more frequent and all the comorbidities are more frequent. And so the point now is, in my view, to think that we needed, aging is not different than the general population. As you get into the geriatric issue, you need to understand who are the most vulnerable people. And so again, I'm a clinician, I'm not an epidemiologist, but my task is to understand what picks the vulnerability of my population. And in my view, the vulnerability of my population is identifying frail people inside my population and identify that for sure there are HIV-specific aspects that make frailty be more common, more frequent, because we know that the HIV history affects frailty. Your nadir CD4, your cumulative viral load, your low CD4 after treatment, all this actually is associated undetectable viral load, co-infection, all this affect frailty in our population. And so, as far as I'm concerned, I believe that really we need to get into the clinical possibility to identify the vulnerability of our population, because we need to have in mind that frailty is reversible and we need to do properly dressing intervention with regard of reversibility. The second point is that frailty is one of the many geriatric syndromes, and we need to think about how to deal with a geriatric syndrome. To do what? What is our objective? It's not just to have people with undetectable viral load, is to promote a healthy aging. And so in my view, and actually it's what JEPO is trying to do, is somehow to change the paradigm. So far what we did was somehow to describe diseases and says, oh, getting old, you get age-related diseases, diseases accumulate, you've got multimorbidity, multimorbidity implies polypharmacy, blah, blah, blah. But now it's time to say, well, is it possible to have a healthy aging living with HIV? Okay, how can we describe healthy aging? And so the process now is, yes, we take care of disease, but we need to promote health. How can we describe health in people living with HIV, and what are the interventions in order to promote it? And so we are somehow in a change of paradigm. This is true in HIV medicine. It's also true in geriatric medicine, to move from looking disease to look into healthy aging.
So Peter, I think that those that started therapy very, very early and with high CD4s do differently than the rest, or the ones that started therapy with less than 200 CD4s. And I wonder if you tease out this data from your cohort regarding the aging, and for instance, in assessing those over 60 that started very early therapy or later, if there are differences between them.
It's a good question. I don't think we can, at the moment, tease it out from our cohort, because I think our cohort is 75% is made up of the patients that Eugenia was talking about, who have a long history, have had a long period of untreated infection, etc. And that, of course, is the largest group at the moment who has aged. So, and we need to take care of them. But I would guess that they're also the group with the highest risk, and the future may change. Whether the future will change completely, I don't know. I mean, if you look at the data of the STAR trial, for instance, closely, and you look at cancer risk, you still see that that's substantial in the group that was diagnosed and treated early. So, and if you look, and somebody showed the data yesterday of, if you think that if inflammation and persistent inflammation is an important driver, and you look at the data in primary infection from Thailand, where you still see, at least if you look at biomarkers, you still see residual inflammation, even if you treat in the first week. If that continues for decades, I don't know. I mean, nobody knows what that would mean. So, but I think we need to keep an open mind that the problem may not be totally solved. I think the other thing I want to bring up, which wasn't brought up yet, is that when we find a difference in these cohorts, and people have done that in the past, the difference is then ascribed to HIV. It's HIV which is doing that. I think what we've learned from our cohort, where our controls was very carefully selected to be as similar as possible, you actually find that there are other factors which are probably very important. So you find a difference, and then you do the analysis, and for instance, a virus like CMV, I think, is playing a big role also in the HIV uninfected population. And at least I think in POPI, but also in our HIV cohort, that uninfected population is definitely not the same as the general population for various reasons. Maybe repeated exposure to pathogens, a higher CMV burden, response to CMV, whatever, and other factors. But I think it's not just the HIV that is driving it. So getting back to Giovanni, I mean, as you learn more about what are these factors, you can start thinking of how can you intervene. And at the same time, I think we know some of the things that are good. I mean, those of you who went on the bus this morning, that wasn't good. You should have walked like us. No, I mean, so exercise and healthy lifestyle, etc. I mean, we found shocking numbers in our cohort in Amsterdam, both in the controls and the people going to our clinic, that we're very bad at managing cardiovascular risk. I mean, we all talk about it, but actually, if you look at the data, how good we're doing at managing lipids and blood pressure, etc., there's a lot to be gained. So I think it's also a more general problem that we're not that good as healthcare providers at managing these things.
Paddy, do you want to add?
So I'd agree with some of the stuff that Peter says, but I disagree with the management. So I think that we beat ourselves up as clinicians, as HIV clinicians, saying that we're bad at doing stuff. But when you actually look at, so for example, bone disease, when you look at the general population, there's very evidence-based guidelines about who should get managed for bone disease, how to do it. When you actually look at the implementation of that, about 10% of the people in the general population that should be screened and treated for bone disease are screened and treated. So I actually think as HIV physicians, we probably do exceptionally well compared to the general population, and I think that's going to be reflected in outcomes.
But do you think that's true for general HIV physicians? I mean, I'm absolutely convinced it's true in Dublin because
I think we probably
you have a specific interest.
Well, I think we probably do better than 10%.
Maybe better than 10%.
I think I do think that our patient population, by being engaged in care, are at a treatment advantage. Whether we get it up to the 100%, I don't know. The issue around the issue around how you approach this, I think, is. I think we need to recognize that there are groups of people that are going to be in trouble, and I think that the key is trying to understand that. I think that it's not so much about how much treatment you've had or where you started. I think it's more about what response you've had to treatment, and it's about what we're dealing with is a host and a pathogen. We know a lot about the pathogen, but we know very little about the host. And we have these surrogates like nadir CD4, and we try and apply these things at a population of, how long you've been living with HIV, what your baseline CD4 is. But that's a very rudimentary assessment of how the host is responding to this infection. And I think for an individual, we need to be looking at how their body responds to the infection as an individual and learn about markers of inflammation and learn about markers of response that will actually predict outcome. And I think that that's the way the field will go. And I think the issues like Sergio's idea around the microbiome, all of the markers that we have around inflammation, we are not going to find the one marker that's going to define a population. What we will find is a number of markers that will define an individual. And then we can use those markers to define how we manage that individual.
I totally agree with that, but I do, and I think our cohorts, one of the reasons why they're valuable and the biobanks are valuable is to try and do exactly that, and come up with what set of markers predicts the person who's going to do badly, and then of course next step, how can you intervene? But I realistically, but maybe you're more optimistic than I. Realistically, I don't think we're yet very. I think we need to strive for that. I totally agree. I don't think we're very close to that because I am also convinced that it's going to be a complex phenotype that we need to come up with, and it's not going to be one single magic marker. Yeah.
Genia?
No, I totally agree that it's time, as Giovanni said, it's time to start interviewing in these patients, to identify these patients and to interview. In fact, the last session of today is about interventions in neurocognitive and functional and geriatric syndromes, no? And for me, the problem is maybe we don't have, in our cohort, for example, we don't have differences between some geriatric syndromes, between controls and infected patients, but we have differences about social markers and about economical problems, more people living alone in our cohort, in comparing with controls. I think that it was 60% or more in our cohort, and this, I think that more frailty and I think that and more cognitive complaints, not cognitive impairment at the moment, but more cognitive complaints, and all of that, the social, the mental, and are negative predictors for the future, for more morbidity and more mortality. So I think that we have to identify these patients, as you said, and start interviewing.
So I think I couldn't agree more with you, because when we look at, so the POPPY study, it's the POPPY study that we run in, so we're a site in Dublin, there's 7 sites in the UK. It's very similar to Peter's HIV in that there's this matched HIV negative control group. And the big thing coming through from the initial analyses in POPPY, and it really is very strong, is the psychosocial aspects of living with HIV and the impact that has on mental functioning and physical function. And I think that's, you know, we can spend a huge amount of money profiling people biologically, but the very clear signal that's coming through is it's a psychosocial issue, and there's a number of reasons for that. You know, there's behavioral aspects, there's stigma, there's pain, you know, there's the consequences of living with chronic disease. There's the neuropathy that comes from the historic drug treatments, and these are very real conditions. And when you map them onto quality of life, they have a significant impact. And we have a separate study in Dublin called the HIV Upbeat study that we've been looking at for nearly 7 years now. And when you look at the quality of life in people with HIV, and again compare it to those without HIV, the big changes over time in quality of life are in mental and physical function. And they are the things that, to me, define the change that happens with HIV, and I don't think that we're paying that enough attention.
So let me make a comment that the sort of messages that we receive through WhatsApp or this through the iPhone. I received one ranking what could explain that you could have prolonged life, and one of them, ranking them, the exercise was not the first one. Probably between 15 was the 10th or the 9th, but having some sort of what the Japanese call ikigai. Having enthusiasm for life and having willingness to do many things and enthusiasm again. So this is what helps more. Of course, exercise is complementing. And I'm saying this as introduction to my question to you guys of how you match your patients for the cohort, because I think that it's not having uninfected over 60 and that's it, because your cohorts have been exposed to a stressful life. Therefore, they smoke more, they had more risk factors that should be also compiled in the comparative cohort. Because if you select an aging cohort not suffering this stressful life, then it's not comparable. And then I would like to know how you select, Giovanni, how you selected your matching cohort.
So I'm very pessimistic on this point of view because in my view, it's impossible to match properly individual because if you go to a perfect matching, that is the HIV cohort in which actually you select from the same STD clinic and they were totally equal to HIV positive except for HIV, okay? Then I think that's the ideal matching. Nevertheless, as Peter said, these HIV negative control are different from the general population. Okay, what we did, we had not the capacity, we wish, but we had not the capacity to do what Peter did, and so we found a, let us say, a first level geriatric clinic. Mind you, the population is different from POPI and HIV because the JPO has got only people above the age of 65. And of course, it's different the health system because we've got a primary level geriatric clinic. And so our population is not selected, is totally different with regard of lifestyle of our HIV patients, okay? But in this situation, what we try to do is now to encourage family members of people living with HIV that are more than 65 and thus have free access to care, because this is also an important issue, who pays for that, okay, to get inside the court. But so far, my understanding is that it's so difficult to find a true comparative that is representative both of the whole HIV population and the general population. Just very short issue, if the more you get in the geriatric age, and so people above 70 years, 75 years, the less they've been living with HIV for a longer period of time. And so the extreme part of the court is made by people who acquired HIV at a earlier, let us say, not so many years, therefore are more similar to the geriatric general population.
Peter?
Yeah, just to add to that, we didn't formally match, just to make that clear. When we started, I mean, this was the time when people were actually, based on no evidence, saying that people with HIV were aging in an accelerated manner. And we decided that we needed to do some science. So we said, well, if we take the control group, we want them to be as similar as possible. And then we said, okay, where could we look? And based on how we did an old cohort study in Amsterdam, we said, let's look at the city center STD clinic, because likely people who go to the STD clinic, they're certainly at risk of contracting HIV. A lot of them are, of course, uninfected, but probably, we didn't know, they may have similar lifestyle. That's how we approached it. And then once we got the data, we saw that we actually had been lucky, in a sense, and that they were very comparable, but it's never perfect, right? And I think the issues like you mentioned about ikigai and mental health and all that, we didn't have much information on that at the time. So there may still be, and undoubtedly there are still differences, but it's as close as we could get. And the basic reason we wanted to do it is because the question we were asking is, what is the impact of having untreated or having HIV, the context of HIV? And the best way to get at that is to make your control group as comparable as possible, but it's never perfect. So that said, I think my message always is, it really depends on the question you're asking, what comparator you take. So the fact that Giovanni's comparator cohort is less comparable doesn't mean that it's a worthless cohort. It's just that you're asking different questions, and when you get the results, you need to be cautious in interpreting your results. But it still has a lot of value. And that, I think, is important to keep in mind. Yeah.
Eugenia, do you want to comment on this?
We match our cohort by sex and gender only. It's not a perfect way, but
age and gender.
Age and gender. But I'm happy because when we compare some aspects that I think that could have an impact in the comparison, such as this economical status and educational level, we have a comparable cohort. So I think that it's not the perfect way, but indeed.
So, which is the oldest guy in your cohort? So, and in your cohort, do you have anyone reaching 100 years?
No, maybe we are
going to publish the first HIV patient reaching 100 years.
We have a relatively young cohort, so we have. I don't think I have maybe 2 patients that have lipoatrophy, for example, out of 1,000. Most of them have been diagnosed within the last 15 years. So we have patients that are in their. We have a group of patients that are in their late 60s to mid 70s, but none beyond that.
Not after. Giovanni?
Actually, I have a patient who is 100 years old.
Really?
Yes.
Come on. I thought that you have that.
He got
that
HIV
patient.
when he was 75. Was quite lively,
So it's an
75
old
icky
rocker.
guy.
He was an old rocker.
No, I mean, the difference, I believe, with the other cohort presented here is that we try to concentrate on just geriatric patients because the objective for us was to describe geriatric syndrome. Okay, and so we were concentrated on geriatric syndrome, and that's why we wanted to get a higher let us say, higher age population to study it, and try also to translate which were the most important intervention. I don't know if I can anticipate, but actually...
Yeah, no, that's then my next question.
Yeah,
So,
okay.
Peter, the oldest you have.
In the cohort.
Yeah, well, outside the cohort, the oldest HIV...
I think in the clinic, 80 plus.
80
I don't
plus.
know whether it's 85 or
Yeah,
84, but
okay.
we have a few, yeah.
Virginia?
My oldest patient is a woman who is 82, but in the last 6 months, I don't know anything about her, so I have to call her because I'm not sure if, yes. No.
So,
the daughter, or maybe, I don't know how to do it.
This 100-year guy was so funny because he says, oh, I'm so lucky because my daughter lives nearby me and the daughter is 75. And so actually, that's...
okay. Let me go back to what you mentioned about CMV, because it's always, is this a cause or effect? Could it happen that because of the dysfunction of the immune system, there are some reactivation of the latent viruses that we get when we are young, and that usually remain controlled, but they are not that well controlled, but they are not really causing a disease. It's just that a marker of what has happened or what has suffered the immune system, or is there a direct effect of this virus? Are there data that show that they are causing a part of Epstein-Barr and lymphomas? And I'm talking about CMV.
The honest answer is I don't know. I mean, it could be true what you say. I don't know yet. And in the clinical studies, I mean, it's associations that we find, so cause and effect are very difficult. We're about to put in a proposal for a grant but this is in an animal model with all the limitations of that, where we're going to try and look specifically at the effect of CMV. So I may know more in a few years, but I really don't know the answer to the question. It's just that it's in terms of associations, it's a signal that we are now getting repeatedly in different types of analysis that we do within the cohort. And there seems to be a contribution from CMV. And we haven't looked at it in a very sophisticated manner. So in terms of CMV, I mean, sometimes it's just looking at whether somebody is antibody positive. Sometimes it's looking at CMV antibody titer. So I think it's early days, but there's a signal there which seems to be worthwhile to explore further. But I don't know. And of course, there's some other studies. I mean, there's the early, but again, early signal studies, for instance, that Peter Hunt has done, intervening with valganciclovir, where you sometimes do get beneficial signals, sometimes you don't. But you know, it's not, nothing of that is like, oh, clearly we're on to something. I think it's early days. Alan may have other opinions about CMV.
So Alan, can you bring the microphone to Alan, to the...
Alan, you have a microphone in the corridor here near you.
But while it's coming, the microphone, Paddy, do you want to add something?
Yeah, so probably the most insightful talk I ever heard about CMV and the immune system was from a colleague of Giovanni, Andrea Cosarita. So he describes the immune system as a defined space. So it's like you have 6 liters of blood, you have a defined space for your immune system, and there's only so much that space can cope with. If you're CMV positive and you're geriatric CMV positive, the geriatric CMV positive immune system, a huge amount of that space is filled with a CMV response, which leaves very little left to conduct the rest of the normal immune function. And I think that all of the signals that we see with CMV and HIV, it's about senescence, it's about the effect of CMV on the immune system. And I don't get any great evidence coming through to suggest that as a virus, as a persistent virus, that it's doing anything. I think the consequences of CMV is the space that it occupies with the immune system to deal with it. And I think that that's something that is well described in the geriatric population. I think that we're seeing it in HIV. I'm not convinced that any treatment of CMV is going to reverse that, because I think the damage is already done. And I think it's just something that we've got to understand and learn how to cope with in terms of trying to look at people that are CMV positive and deal with the immune consequences. But I do think it's in a form of immunodeficiency rather than a chronic infection.
Alan?
Yeah, I would certainly agree that as you age, you expand your immune reactivity, and almost up to 50% of your CD8 cells will be CMV specific. In the studies in aging, the immune aging phenotype includes the idea that if you're going to age, you're CMV positive. People who actually survive in healthy populations, the OCTO and other big studies in Sweden, they remain CMV negative. So there is some effect in terms of how long you can live. In the HIV populations, we are in the AIDS clinical trial group program at least going to look at 2 interventional trials that are going to be upcoming in the next couple months, one with the CMV vaccine approach, and then one with the new antiviral letermovir study. So both of those are all ready to go forward. I can agree, we'll see, the data will prove whether it works or not. And I think for all of the questions that we ask, how do we prove whether there's a real effect, is we have to do the interventional trials. And that's where, in a lot of cases, for the inflammation, we have had no effects. I mean, that's been one of the problems with a lot of our studies of targeting. We heard a lot about microbial translocation yesterday. We've targeted that in a number of studies and had seen no outcomes. So I think, and we're also looking now at the role of statins, the pitavastatin reprieve study, which is 6,000 patients. And I think the history has taught us that in HIV, we started with IL-2. We knew with all the early studies until we went to SILCAT and Esprit, we didn't find out what role of IL-2 was, and it was more of a negative than a positive role in terms of the outcomes. And then we had SMART and START based on all of the trials of looking at whether or not you go on drug-free holidays and all of those, and that's what took us to those 2 big trials. So I think that's where we are now in the inflammation space. Now, if reprieve doesn't show anything on an impact, you know, where do we go from here? And I think that is the question of, I would actually like to ask the panel is, what do we do therapeutically? How do we, you know, you've talked a lot about defining the syndrome, but, you know, Giovanni, you said when you have that patient in front of you, you can get all the biomarkers you want, but what do you do for that person? Do you put them on a statin? Do you give them aspirin? What is it that we should be doing clinically as the patient comes in who's now 50 or 60, and how does that go forward?
Yeah, thanks for your comments, Alan. as usual, very, very interesting. And I do think that we do, when we do clinics and we face patients, we need some placebos but not for our patients, for ourselves. Because we need to prescribe, because we feel more comfortable thinking that perhaps we could do something in front of that inflammation that we are facing. And then, as Alan said, so please, could you all of you respond on how you manage this inflammation? Do you prescribe placebo for yourself, for your patient? Or are there any data supporting any benefit from any drug?
Well, no. I mean, I agree with Alan. I mean, the small studies so far have been really disappointing. So I think Reprieve is the big one that we're all waiting for. I don't actually know when it's scheduled to, by another year. And then, of course, again, the issue may come up that there may be subsets of patients that benefit and others that don't. So we'll get back to the question of how do you select your patient. I mean, to me, listening to the talks yesterday, to what Alan just said, there are all these potential pathways that you could intervene. And maybe ultimately we'll be looking at combinations of interventions, and the question is how do you do the science to get to that combination? So a question I had to Alan actually, is there any sensible animal model that can be used to test that, because it's going to be unaffordable and impossible to do Reprieve-sized trials for clinical trials for all those combinations. So I'm not sure how we're going to move forward if we don't have a model system where we can get information. I know there's some groups in the US, I think, who are looking at non-human primates and use those models to, but how sensible, how good are those? What's your opinion?
Well, I'm actually doing those studies, and we've published, we've done interventions in the non-human primate, both in the African green monkeys, which is the non-pathogenic, and then the pigtail macaques using the same virus, and looking at those outcomes. And what we found so far is if we treat acutely at the time of infection, that we can affect the viral load with no antivirals, but simply with a blocker of microbial translocation. So you can have at least some effect in showing that. But then when we move into the chronic phase, where most of our patients are, we don't see that effect. So sevelamer, rifaximin, sulfasalazine, all of these we're trying. I mean, we're looking at other approaches as well. One of the things that we're doing now in a recently funded study is diet. So we're asking the whole question of what does diet do, and how can we manipulate the diet overall. We have some work coming out on a high-fat diet, and this is Ivana Pendria's work, University of Pittsburgh, where if you put on a high-fat diet, that causes the mortality in the animal models. And so there is clearly an effect of diet, and I think that's another question to the panel, is we always bring up lifestyle. We've talked about smoking, we've talked about diet, we talk about drugs in the, probably in the US and other places right now. The opioid epidemic is huge, and that's getting huge attention in the US, and it's where all the funding's going. So if you ask where is the funding, it's not actually going to HIV anymore, it's going to, there's two areas in the US that get all the money: opioid epidemic and now Alzheimer's disease. So if you come to the US and want to do work, that's what you work on for the grants. And I think that's the question to the panel too, is how do you look at, what do you advise your patients? You mentioned exercise. I think we can use the non-human primate model. I don't think it's given us any evidence that these trials or these agents are necessarily going to give us any more insights at this point in time. And I think it's just, at least they've been negative even in the chronic infection.
Giovanni.
So I try to summarize what we do in clinic. And so first of all, you need to understand that different health systems differ, okay? And so actually in my health system, we take care of the patient as a whole, okay? Because GP's role is almost null in our system, okay? Given that, I think we need to distinguish what we have to do in what we call the people getting old with HIV and in the geriatric patient. It's a different issue with regard of management. Okay, in both of these groups, what is important is to have an holistic approach that is not just to take care about their disease or health, but also about their social environment, because we said before that the social environment and all the situation related to disadvantage that many HIV patients have will have a strong impact both on disease and on health. In a non-geriatric population, the issue now is to do as much as we can as prevention medicine. And so preventing cardiovascular disease, preventing diabetes, and so on and so forth. And so our approach is try to be somehow proactive in introducing early stage drugs that will work for primary prevention. And so that's why our key drugs are antihypertensive drug, are statin, and are anti-diabetic drugs, which are the most important issue. The important thing is, in this context, what are the best antiretroviral regimen that should be prescribed? Should they be used also in a preventive strategies, yes or not? That is, should we avoid boosted regimen? Should we avoid tenofovir-based regimen? Should we avoid TAF-based regimen and getting into dual therapy if this is effective? Of course, the starting point is to have effective antiretroviral drugs with regard to the best marker we have, that is not just below 40, but undetectability. But as soon as you switch into the geriatric setting, imagine a patient who is 85 years old, and we've got 80 plus people. Of course, all this prevention may not be the key points. The key point is to manage geriatric syndrome. And so the issue is that up to a certain point, we introduce drug to treat comorbidities. After a certain point, we realize that we are growing into a polypharmacy situation, and polypharmacy itself may be the reason why you have lots of geriatric syndrome. And so we need to understand that managing polypharmacy is the key aspect of managing geriatric people. That is understanding that it's not just an issue of drug-drug interaction, which is a big deal, but also an issue of potentially inappropriate drug prescription that may cause harm, may cause neurocognitive impairment, may cause fall. And so the issue now is try to learn from geriatrician how to manage potentially inappropriate drug prescription and start deprescribing if we believe that some drugs may affect geriatric syndrome. This is what I currently do in my clinical practice in the geriatric situation. Going to lifestyle, I totally agree that diet is fundamental. We heard beautiful lecture yesterday by Dr. Blanco about sarcopenia. Now we currently check the protein intake in our patients. We realize that actually lots of our patients have hypoproteic diet because protein costs a lot of money, and if you are in a social situation in which money is a problem, you may turn to have, let us say, no access to protein, adequate intake, at least 1.5 grams per kilo a day, okay? And so we try to promote a hyperprotein diet, and we try to promote physical exercise in a setting that may be cheap and affordable to our patients.
Paddy, all the colleagues didn't mention what they really prescribe. So they were talking about exercise, diet, proteins, and whatever. But what sort of magic pill you have, Paddy, for the inflammation?
So the one strategy that's been shown to work, it's the only strategy in HIV that's been shown to work that's a switch strategy that impacts on improvements in mortality, is switching away from cigarettes. And if you talk about what we do away from cigarettes, evidence-based, it's a big issue in HIV. It is the one thing as physicians, out of all of this, that we do badly. Because we have the evidence to show that it is impacting on a range of comorbidities, but yet we still have smoking rates that are approaching 50%. So I think that's the big thing that I have in my clinical practice. I look at someone coming in who's older with HIV and they're smoking, and I go, this is not a good mix. Everything else that we do, we like switching antiretrovirals, we like giving people drugs for inflammation. I think all of the therapeutic strategies in HIV targeting inflammation are premature. I think that the studies have been poorly designed. I think that we are doing harm, and the studies have actually shown that low-dose methotrexate in older people with HIV does harm rather than benefit. And I think we need to take a step back, do the things that we know work. I think that the lifestyle advice is important, but I'm a pragmatist. I give someone lifestyle advice, I tell them to exercise, I tell them to eat more. It doesn't work. But I think that the one thing that I will do is annoy people constantly about smoking, because I think it does work. And I think that I see myself as like the husband or the wife of the patient. If I keep on annoying them enough, every time they come in to see me about smoking, then eventually they'll get the message.
So my humble point of view is that although we might insist, or we can insist on additional therapies apart of the antiretroviral treatment, the majority of, at least my patients, they do not adhere to that. So when I prescribe statins, aspirin, or whatever, and I see them after 6 months, I realize that they only follow the antiretroviral therapy. So we did pretty well convincing our patients of the need of adherence to antiretrovirals. But regarding the rest, they always think that these are transient, that these are not really needed, and that why to stick to that recommendation, and better just to keep taking the antiretrovirals. So when we plan to analyze the impact of what we are prescribing, we should bear in mind how we are assessing the adherence that our cohort they have had, because in my point of view, they skip many times the recommendations and the therapy. Well, because okay, Pedro.
Yeah, I have a comment on what you just said. Let's think about a cohort of people in their 60s, 70s, 80s without HIV. How more adherent would they be to their statins and their antihypertensive drugs, etc.? What I mean is that maybe we are asking our people that on top of being old, on top of having the geriatric syndrome very well described by Giovanni, they also have HIV. And yes, they learned that if they stop their medicines, viral load will go up, CD4s will go down, and they will eventually become sick and die. But they know that what happens if I stop my statins? I take rosuvastatin every evening, and guess what? Nothing happens, at least in the short term. And when you are in your 80s, what is the long term? This is the other issue. I still can recall a patient of mine, when I told him to quit smoking, I said, "Doctor, I'm 79 or so. So what else, what more will provide me to stop smoking? Maybe 6 months, 1 year? I prefer to continue smoking. I'm not advocating in favor of tobacco industry. Don't take me wrong, but I mean, we need to also understand what it means to think in the kind of long-term, long run for a patient in his 80s or so. No, so we need to be a little bit more complacent, I think.
Okay, Paddy, last comment. And
so I agree with that. The one thing that I've learned in medicine from doing internal medicine is that when I talk to someone with HIV and I ask them what medications they're on, they can tell me what medications they're on. Every other patient that I talk to and I say what medications that you're on, I'd say 80% of them can't even tell me. And if they can't even tell me what they're taking, you can guarantee that it's likely that they're not taking it too well. So I think it does go back to this essence of what we do well and what we do badly, and what happens well in the general population. And you're right, I think that we actually do quite a good job for primary prevention, for secondary prevention, and I think it's reflected in the outcomes that we already have. So I don't think it's all bad news.
Giovanni, last comment, otherwise you will lose your flight.
I'm optimistic on the fact that, generally speaking, the level of, let me say, engagement between the patient and the physician on treatment is higher than the general population, because our patients have been learning year by year what the reason why they are taking drugs. And so my clinical practice experience is that if they take a statin, they know why they take a statin. If you go to the general geriatric population, the statin is the yellow pill. Rosuvastatin is yellow, isn't it? And so actually the issue is that I'm optimistic on the fact that actually we can promote education in our patient better than what we do in the general population.
Okay, so join me applauding these guys because they did a terrific work. Thank you, and hope you don't lose your flights, and hope to see you next year. So thank you. So and now we move on to the next presentation, and let me invite me to Marta Vasiliev and Gordana Dragovic, that both they will present and discuss the results from questionnaires to patients. Please.
Thank you to Eugenia and the scientific committee for inviting me to present the results of patient questionnaires. And next 15 minutes I'm going to spend by talking about patient needs in aging people from 4 countries: Spain, Argentina, Serbia, and Ukraine. I have no conflict to declare. Aging HIV person comprise a unique population at risk for illnesses and syndromes traditionally associated with the elderly. Over past decade, factors including an aging, long-surviving population, multiple comorbidities, polypharmacy, and the need for chronic disease management have led to further evolution of HIV care models. HIV-specific expertise and comprehensive primary care with an integrated patient-centered approach should be used for HIV aging population. Here you can see the principles of patient-centered care. It is the practice of caring of patients and their families in a ways that are meaningful and valuable for each individual. Providing care that is respectful of and responsible to personal patients' needs and values, and ensuring that the patient values are a guide to all clinical decisions. Using the weight range on factors, it is focus group recently discharged patients, family members, physicians, and non-physician staff, combined with a review of pertinent literature. Researchers from Harvard Medical School, on behalf of Pickers Institute, invented the 8 primary dimensions of patient-centered care. The first is the respect for patient preference. The next one is coordination and integration of care. Then it is information and education, physical comfort, emotional support, involvement of family and friends, and continuity and transition. And the last one is access of care, to care. Health needs. In our study, we were focused on the first issue, respect of patients' values, preferences, and expressed needs, because health needs in elderly population is very different, and the clinicians face additional changes and challenges related to aging. To offer appropriate and excellent management, care providers should just ask the questions: ask the patients what are their needs, organize focus group, and moving beyond a traditional approach. So our research questions were: what are the health needs of the elderly population, and what are the needs in different parts of the world among HIV aging patients? We enrolled 351 participants in the study from 4 countries: Spain, Argentina, Serbia, and Ukraine. And selection criteria, it was the patients over 55 years of age. If you see the distribution of patients by countries, we have 100 to 124 patients from Spain, 47 patients from Argentina, 106 patients from Serbia, and 64 patients from Ukraine. The mean age of our study group was 61.6, and we had 73 males and 73% of males and 27 females. The method where 8 questions were used to collect information about. First, it was the open question, what should be changed, added to the current medical appointment. It was an open question, and patients used a variety of answers. Then we measured the level of satisfaction by care provided in medical center, management of psychological, functional, social, and sexual problems. The patient had several options to answer, from very satisfied to not satisfied at all. Then we learned from our population how many numbers of visits to the doctors they would prefer per year, from 1 visit to 4 visits per year. And the last question was, who should manage other disease? And they have 3 options of answer: HIV clinician, general practitioner, and other specialty doctor. So now we are moving to our results, and by countries, we selected the top most frequent answers. And we will start from Spain, focusing on the first question, what our patients would like to change in their current medical appointment. So in Spain, the patients would love special attention to psychological problems. Then they would love to have more flexible working hours of the doctors, evenings and weekends. We were quite surprised to see the demand of parking among Spanish patients, but probably it's very important because a lot of patients were focusing their attention on this. Assistance with social problems and routine medical care in HIV unit. Next country is Argentina, and the needs are more time with the doctor during appointment, sexual education, social assistance, additional specialty doctors in the clinic, and better explanation of treatment and strategies that are used for the patients. As we move to Serbia, the patients from Serbia would prefer decreasing the waiting time in the clinic, routine medical care in HIV unit, more time with the doctor during appointment, telephone contact with the doctor, and improved condition in the hospital. And our patients from Ukraine, they would love to have additional privacy and during the appointment, and it is very true because for our Ukrainian patient it is very important to keep the confidentiality, and unfortunately it's not always like this in my country. Schedule the appointments to avoid waiting time, 1 pill regimen, less bureaucracy in receiving medical care, and friendly staff. So to conclude my talk, HIV aging patient needs will different depending on geographical location, and target care and services for HIV aging population should be based on the individual patient needs, and each clinician should remember about this. There are commonalities in needs such as requests for social and assistance, for example in Argentina and Spain, increasing the time of doctor's appointment in Serbia and Argentina, decreasing waiting time in Serbia, in Ukraine, routine medical care in HIV unit in Serbia and Spain. But however, each country, and I think even each region of each country has a special needs. Again, available parking in Spain, sexual education in Argentina, telephone contact with the doctor in Serbia, more privacy and less bureaucracy in receiving medical care in Ukraine. Prospective studies would be very helpful to know, to learn, to better understand larger scope of needs of HIV aging population and determining factors to improve treatment result based on patient needs. My colleague will continue with further results of our study. Here are my acknowledgements. Thank you.
Yeah, but it doesn't work. Can somebody? Thank you. Okay, good morning, everybody. At first, I would like to thank Eugenia for inviting me to be a part of the faculty members and to present the results of the questionnaire. Before I go on, I will definitely talk about the patient needs, especially those 4 picked countries. But before I show you any of the results, I would rather go back and mention those 3 1990 and the 4th which we are all waiting to see what is about the quality of life. And since we can measure those 3 quantitative measurement, here it's really difficult to say what will be the quantitative outcome about the quality of life in those patients. So maybe we can really go in the future back to our patients and ask them questions about how they feel the quality of life. So the aim of this presentation is to show are there any different needs in the different parts of the regions in aging patients. So as you might see on the conference website, there is a link with the questionnaire, so you can fill any patient of the region who speaks English could fill in the questionnaire. But during our preparation with Eugenia and Maria, we decided to pick 4 countries and we translated that questionnaire in English. So, and then from English to our local languages, distributed that questionnaire to our patients, and then we go back and fulfill online form just to be sure that we have enough patient number. As Marta also already mentioned, we have 350 patients in total picked from those 3 different regions. And geographically looking, that is across the world, or let's say worldwide, we have country representative from East, Southeast Europe, West Europe, and Latin America. And the age of those patients is more or less the same, in all cases 55 plus. And then the majority of our patients in all 4 cohorts are males. So what is this is what are the results. Regarding the first question, do you believe your needs resulting from the physiological, psychological problems, depression, anxiety, including sleeping disturbance and other psychosocial problems, are being well managed, covered by the medical personnel and healthcare system? So how did I present the data? It's not like traffic light syndrome, traffic light, like blue, orange, and yellow, but I picked cold and hot colors. Hot means good, and they are happy and satisfied, and blue and green not being satisfied. So I'm not gonna go in a deep details like particular numbers, but what I'm gonna show you that regarding that question, overall, it is more than obvious that people from Spain are the most satisfied with the healthcare they receive. So red and orange is predominant patient answer. Here in Serbia, patients are also very well satisfied, and in contrast with this, Ukraine is having more work to do in terms of covering psychological problems in their patient population. The second question we asked in the questionnaire was, do you believe your needs resulting from the functional problem between visual and mental impairment, mobility problem, etc., are well monitored and studied? And again, Spain had the most frequent response, like satisfied and very satisfied. And again, Ukraine as well as Serbia really needs to work more to cover that field much better than it is covering right now. In Latin America, it's almost half-half, so there is more work to be done there as well. This question is very tricky because we asked them about do you believe enough attention is given to cover your needs arising from the sexual problems? And the fact is we haven't asked them, do you have a sexual life or are you sexual active at all? So those who respond in yellow, when we go back through the details, are actually not having sexual life at all. There are no data in the literature about, or maybe not enough in the HIV field, about the sexual life in our patients after 55 years old, which is another completely different and not well-studied field. However, we still see that, again, in Spain, people are in majority who said that they are very satisfied with the sexual, how doctors cover their sexual problems. Similar, or more likely similar, like in Serbia, and then followed by Ukraine and Latin America. However, this is really strange and difficult to discuss because sexual needs are different, and is it a matter of quality or quantity? That's another thing which could be discussed elsewhere. However, it is still interesting that we, for instance, in Serbia, regarding the question, what is the oldest patient in our cohort having HIV, and that is our patient who is born in 1929, so he's 87 years old now, and he recently got the AIDS via MSM contact, and then transferred it to his wife, who was 2 years older than him, recently died. So it's really difficult to say how to manage this thing. And then we also asked the patients, are you satisfied with the attention you receive at your medical center? So if we again look through the colors, people and patients in Spain are the most satisfied, followed by the Latin America. In Serbia and Ukraine, we have predominantly satisfied, but very few very satisfied patients, so we also need to do more work in that perspective. Then we ask them, patients, how many times do you think the doctor should see you, HIV doctor? So this is interesting. In Serbia, they said once a year, but that is quite reasonable because we prescribe antiretroviral treatment once monthly. So we see our patients 12 times per year, which is hard work to be done, but that is how our health insurance system asks us to do. So they are pretty sick of visiting us, and that is probably why they ask respond once per year, while in Spain, majority of people answered 2 times per year, and then follow again with the Spain 3 times per year, while in Latin America, patients are willing to be more often seen, like 4 times per year. Then we ask them who do you should control the other diseases you may have, like HIV specialist, family doctor, and other specialists. And obviously, the majority of people choose to pick HIV specialist. In, I believe, many of countries which are included in the study, HIV specialists are those who are following the patients and know the best, not only HIV status and how to treat disease, but other problems. So that is probably the reason why they picked to be treated by the HIV specialist. But surprisingly, general physician was the second option, which I don't know how in Spain looks like, but in many countries, GP is not predominantly involved in the treatment of infected patients, so that is really surprising answer. And we have more data for the questionnaire to present, but I think that we, in the future, need to improve our questionnaire, or maybe to distribute it worldwide, to go more east and to see the different regions, what will be the response. So to conclude, definitely age-related comorbidities will have a profound impact on already challenged healthcare delivery system. So our study indicated that the aging HIV infected population is in need for functional, psychological, and all other necessary support. Definitely need to acknowledge, and thank you. Okay, so Eugenia has something to...
No, you can.
Yeah, so if there are any other comments or suggestions or criticisms, please.
My question to you is, from the UK, do you have any pharmacists in your clinic that sit and talk to patients about their medication, or on the ward?
Thank you for the question. I can speak only for Serbia, where I'm coming from. So in our hospital, unfortunately, we do not have a pharmacist. The only person who explains how to take the drugs is a doctor himself. And let's hear about the Ukraine.
I could tell about Ukraine. Unfortunately, also, we do not have the pharmacist in our clinic. I know about Spain that there is a pharmacist in the hospital, but I'm not sure about Argentina. Maybe the colleagues would help me. How about you do have? Yes.
Okay. Thank you. Other questions? Eugenia has a question.
Yeah, thank you very much for presenting this data. I think that it's important to know what our patients needs. No, I think that we should, as you said, to continue with these questionnaires, with more, including more countries and more patients, and. It's a comment, it's not a question. It's just to say that probably not, I'm sure, that at least in my case, I don't ask directly to my patients about sexual problems, about sleep problems, about other not medical problems. So, and I think that considering these results, we should do it. You know, it's just a comment.
Yeah, thank you for adding this. This is very interesting because in our very busy clinic, sometimes you don't have enough time to ask the patient. And this questionnaire itself, from my perspective, is very well structured, and it is going in the deep details, asking questions which maybe we can't ask on the daily basis, and which give us a kind of feedback which we probably wouldn't hear from our patient on a regular daily practice. That is why we definitely need to go back and see the patient needs. If you really want to reach 90 and 90, like a quality of life, that is really necessary, because we don't have, I went to the public health department asking them for the support at my university, and we did a PubMed search which shows that there is very few, not that recently published paper showing us about the patient needs in HIV, not aging patient, but in general HIV population, which might show us the way that we really need to continue with the questionnaire and to maybe do validation questionnaire, to do more research, to really see what are the patient needs in deeper, so that could guide us for the next coming steps. Okay.
Maybe. Also, using this opportunity, there are a lot of people from different countries, and maybe you would like to participate in such questionnaires in the future. Please take it in mind that we would be very happy to invite you to be our participants in the future and to enlarge the number of countries. And we will design a little bit, update our questionnaire. So please, you are welcome.
Anna, please.
First time that you have published, presented this on the previous, like 2 years ago, it was also I went around England and presented these results, and everybody were giving a feedback that, of course, UK would like to participate. Sorry. And the thing that I think it's very important is that we are creating all these specialist clinics, offering the patients things that maybe are not important for them, so there are lots of appointments that patients are not coming because they don't consider it relevant. So do you think that there is, what are your suggestions for more questions to be added in the questionnaire in the future? Do you have something in mind already, or you are thinking about it?
We definitely need to do more research in terms of what to cover. But at the moment, what I have in mind already is to discuss about the social life. Are they alone, or are they with a family? How do they feel the support? In terms of functional problems, with emotional problems, that's another field which definitely needs to be discovered. But at first, those capability to walk or to do some things on their own in the home or in the neighborhood. So that is the first thing which definitely impacts their quality of life, and then move on other issues which definitely needs to be request a deeper research.
So
maybe, we do not have specific questions we would like to add, but we will look back to this model of patient-centered care, and we would design our future questions and additional questions on these needs, which are defined like 8 principles of patient-centered care.
And
this questionnaire was designed, as you said, 2 or 3 years ago in the first meeting that we did, and we decided general questions just to identify the most, the more important needs. But if we want to continue, it's important to specify in each section, in social aspects, in functional, and maybe we should include more
countries, more regions,
more patients, more countries, more specific questions. But we should try not to do a very long questionnaire, because in these cases patients are not involved. So,
okay, we have one more question in the back.
Thank you. Very interesting. It's not a question, it's more of a thought. For the graying of AIDS, we have a lot of different kinds of questions that were our own or were requested, submitted by a variety of people. And I just want to applaud opening with a qualitative or open-ended question. That's where the surprising things happen. And I recognize that a lot of the folks who are presenting at this meeting are coming from a kind of hard science orientation, and we like to quantify things, but I'm very pro-qualitative research, and I think you might find a lot of really interesting and surprising things if you continue to include qualitative questions in your questionnaire. The reference to parking in Spain doesn't surprise me at all. In talking with over 100 people at the 3 different international AIDS conferences that our project was involved with, a lot of people talked about difficulty with transportation and accessing services. And that's, as clinicians, you're so reasonably focused on dealing with the person in front of you, it's easy to forget that they had to get in front of you first. And that's the sort of thing that would only come up in a qualitative question. So thank you for including a qualitative question, and I strongly encourage you when you revise the questionnaire to include more, to see what other surprises you come across.
Thank you. Two questions, so I thought ladies first, but no. Now let's be pragmatic.
Okay. It's very interesting. Have you thought about including or asking these questions to younger patients in your clinic to see if the differences are age derived or are due to just general interests or needs in HIV patients?
Thank you for answering. That would be very interesting to compare different age group. We do not have it in our nearest plans, but maybe in future it could be discussed. And also, I would like to invite some partners to this study. If you would like to be involved, you are very welcome.
In fact, according to my knowledge, this is the only conference of this or any kind going back to the patients, asking for their needs, because what we think as a doctors and professionals is one perspective. As there is a comment from the public, they definitely have their own needs. So we started, in fact, Eugenia started with the aging population for the purpose of this particular meeting. But a good idea, and thank you for addressing this issue, maybe in the next coming future. Thank you. And probably the last question.
Yes, thank you so much for the good presentation. I was going to make a request that can that kind of research be also be duplicated in Africa, because our lifestyles from developing countries, underdeveloping countries, it's very different. And it has a huge impact on people who are aging with HIV. In Africa, mostly in sub-Saharan Africa, we have problems of poverty, we have problem of climate change, we have disasters, we have conflicts. There is gender-based violence even among those mature people living with HIV. So I would recommend that a study is carried out also in Africa so that we can compare, because our lifestyles are very different. I come from Zimbabwe, and right now we have a cholera outbreak. I think some of you have read in the newspapers and in the media. So that again has a bearing to an older person who is living with HIV. And like I said, the issue of poverty, good nutrition, etc. And as people living with HIV, I like the first slide she put. We talk about positive health, dignity, and prevention. I don't know how many are aware of that term. This is where we are saying, as people living with HIV, we are not vectors of the disease, but we can play an integral part in HIV prevention of new infections, in also program design, program implementation, monitoring, and evaluation of programs that are of HIV programs at every level, from community to national level. So I'm going to request that the research is also taken to Africa and maybe Asia, so that we compare the lifestyles of people who are HIV and aging. And last but not least, yes, the agenda for aging people with HIV, it has been undertaken. Even when it comes to funding, all funding is going to key populations, that is the young people and other key population, MSM, LGBTI. And the moment you try to put issues of HIV and aging on the agenda, especially for elderly women, no one really listens to us. So I would like to thank the conference organizers for this unique conference, whereby we are now being given a voice and a platform. And we hope we'll get some of the slides, because we really want to go and adjust our programs back home to now amplify the voice of people who are aging with HIV. Thank you.
Thank you. Exactly what you are saying. There is not much research being done in the elderly, not basic research, but this kind of research. And it is also established that doctors dealing with 50+ people are also need to update their knowledge. And regarding the second comment, yes, everybody are pretty much welcome to be the part of the questionnaire. So far, we included just the part of the world covering East and West Europe and Latin America, but in the future that could definitely be changed. So after this session, maybe you can talk with Evgeny and us to make a kind of first agreement about dealing with the question.
Thank you for your active participation, and I hope that for the next meeting we would be able to present 2 additional slides from Africa and from Asia, not covered regions yet, and coffee break. Yes? Thank you.